Welcome to this yet another interesting module on the antibiotic allergy and the cross-reactivity pattern. So, many of the patients who come to the hospital and emergency say they are sulfur allergies, they are penicillin allergies. So, we tend to go overboard and go for a carbapenem drug because they are penicillin allergy and even avoid ceftriaxone for that reason. So, to know more about this allergic reactions and for your knowledge, for a penicillin allergic patient, ceftriaxone is actually safe. So prescribe confidently after watching this module and understand the basics and the concept behind the antibiotic allergy and the cross reactivity. From the immunology to blood set clinical decision making, we'll learn in this more video. If you're new to this channel, do like and subscribe. Let's get started. So in this video, we'll understand what true drug allergy is, and differentiate allergy versus non-allergic reactions of many antibiotics, learn why cross-reactivity occurs, and master the side chain-based selection. We'll know more about this side chain-based selection in the upcoming slides, and apply the concepts confidently in the bedside and the ICU, and prescribe the appropriate antibiotic. So drug reactions is not equal to drug allergies. There are multiple categories of drug reactions. Basically, true allergy is actually mediated by immune IgE or T cell mediated. It actually presents with urticaria, anaphylaxis, or Steven-Johnson syndrome. So in these cases only, it is considered as true allergy, and cross-reactivity is very much possible. In case of pseudo-allergy, with direct mast cell disintegration and release of mast cell mediated enzymes, can lead to vancomycin-like reactions like vancomycin-Tedman syndrome. The structure is often irrelevant. So it is because of the direct mast cell degranulation and side effects such as pharmacologic GA upset in case of amoxicillin, it is not allergic reaction. And idiosyncratic, the mechanism is often unknown. For example, like DRESS syndrome, and often it is drug specific. So cross-reactivity matters only in immune-mediated allergy. So basic now you must know that vancomycin-Redman syndrome is not actually an allergic reaction. It is a direct mast cell degranulation issue. The true allergy are actually mediated by IgE and T cell that we'll understand more in the upcoming slides. So this distinction truly matters because mislabeling of allergies leads to going in for more broader antibiotics and more resistant developments, higher cost, and also worse outcomes in some cases. So most antibiotic allergies are not true allergies. These are often pseudo allergies that are mislabeled previously in the past of the patient, and the patient keeps on during their lifetime say they are allergic to this. So it is also said that more than 90% of the penicillin allergic patients are not actually allergic to penicillin. So you must know how to delabel the patient from that they are not allergic. So Gell and Coombs classification, this is the classification that is type 1 to 4 allergic reactions or hypersensitivity reaction. We all know that type 1 is mediated by IgE, type 2 mediated by IgG, and type 3 mediated by immune complexes, and type 4 by T cell mediated reactions. So type 1 is anaphylaxis and urticaria that is most commonly occurs due to drug reaction, or type T cell mediated like Steven-Johnson syndrome, toxic epidermal necrolysis, and DRESS syndrome. Some vaccines can also cause serum sicknesses like type 3 hypersensitivity reaction. So clinical relevance, type 1 and 4 are matter more clinically in cases of drug reactions, and cross-reactivity is mainly type 1 IgE mediated reactions. So this is the single most important concept, that allergy is directed against the structure and not the drug class name. This is where the most doctors doesn't know the concept, and it is over prescribed. So cephalosporin allergy and penicillin allergy is not the same. So it is not the drug class. It is based on the structure. So it is based on the specific molecular structure of that antibiotic that determines its cross reactivity in allergy. So beta lactams. So basically, we must know what is beta lactam. Beta lactam is a ring strike structure. It shares a four-membered ring. All these beta lactams share this four-membered ring. This four-membered ring, of which the side chains in everything is different. So in penicillin, there is no R side chain, whereas in cephalosporin, we label it as R1 side chain. In monobactams, there is a different type of side chain, R, and this also has an R2, and Carbapenems has different R1 and different R2. So all these side chains, this side chain actually determine the allergic reaction and not the drug class. So beta lactam allergy, penicillin allergy is not equal to cephalosporin allergy, and penicillin allergy is not equal to aztreonam allergy. So penicillin is sensitivity reaction is allergic reaction is not equal to carbapenem allergy. This ring is not the main allergen, so we'll go for the upcoming slides. So true allergenic determinants is the side chains, that is the R1 and the R2. Immune system recognizes side chain similarity, main determinant of cross-reactivity, and minor determinants like drug degradation products like penicillin oil. Cross-reactivity occurs when side chains are similar. So this is the core concept that you must need to know from this entire video. Penicillin is a cephalosporin, so penicillin allergy is not equal to cephalosporin allergy. So previously there was a myth: if the patient is penicillin allergic, avoid all cephalosporin. That is a very false concept. It was originated in 1970s, contaminated drug batches. It's not supported by the modern immunological society. So in case of penicillin allergy, you can definitely go for a cephalosporin drug. The modern concept, same R1 side chain. If it is present, there is high risk of cross-reactivity and allergic reaction. When there is a different R1 side chain, very low risk. Same class but different structure is often also safe. The clinical paradox, why ceftriaxone is tolerated despite cephalosporin allergy. So most cephalosporin allergies are not equal to ceftriaxone allergy. Ceftriaxone is again a different kind of cephalosporin, a unique cephalosporin group of drug that we have already discussed in the third generation cephalosporin module. All these cephalosporins are given once at more than twice a day or at least twice a day. Ceftriaxone can be given once a day due to high protein binding, and also because of this R chain also it is a bulky oxamino side chain. It is not similar to cephaloxin or other cephalosporin drugs. So cephaloxin has R1 side chain aminopenicillin like, whereas ceftriaxone has bulky oxamino side chain. So cephaloxin allergy is not equal to ceftriaxone allergy. So there is no structural similarity, no IgE recognition. So if the patient is allergic to cephaloxin, label it as cephaloxin allergy and not cephalosporin allergy. Reality is actually cephaloxin side chain allergy. So now we'll know what are the drugs that cannot be given in cephaloxin allergy based on the side chain. So practical side chain logic. So in case of amoxicillin allergy, don't go for ceftriaxone. And in case of ampicillin allergy, don't go for cephaloxin. And in case of ampicillin allergy, again, don't go for cefaclor. All these have the same identical side chain. So avoid if also this is also important point. Avoid only if there is true IgE-mediated reaction like urticaria in Steven Johnson syndrome. Those kind of features, and not just for rashes that can be due to direct mast cell degranulation. Usually safe in penicillin allergy, distinct R1 side chains. So in case of penicillin allergy, you can always go for ceftriaxone, cefotaxime, ceftazidime, and cefepime. All these are very safe in penicillin allergy because of different R1 side chain. So the core rule this you have to memorize is that IgE beta-lactam allergy cross reacts only when the R1 side chains are identical or very similar. So R1 is the primary determinant, R2 can be minor relevance, and ring is rarely the culprit. High-risk cross-reactive groups. Aminopenicillin side chains like amoxicillin have aminopenicillin and ampicillin have aminopenicillin. These are basically the aminopenicillin groups. Cephalaxin, cefadroxil, and cefaclor have the same aminopenicillin group, identical R1 side chain. This has the most common real cross-reactivity clinically. So other important groups are methoxyamino groups like cefuroxime, cefotaxime, ceftriaxone, cefepime. All these groups have same methoxyamino group. So when you have a cefuroxime allergy, that is a also a third generation cephalosporin. Cefotaxime is also a third generation cephalosporin. Ceftriaxone again a third generation cephalosporin. Cefepime a fourth generation cephalosporin. All these have the same methoxyamino subgroup or R1 chain. So avoid this in when the patient is cefotaxime allergy, don't go for ceftriaxone, go for other group of drug. Don't even go for cefepime. So it is rare, but it is relevant and documented in IgE-mediated allergic reactions. So exception is ceftazidime mastery. So it is an exception because of specific cross-reactivity. Only clinically significant monobactam exception is the ceftazidime avibactam. The lower risk and safe options. If there is patient is penicillin allergy, you can go for ceftriaxone. If the patient amoxicillin allergy, you can go for ceftriaxone. Ampicillin allergy, again you can go for cefotaxime. Cefepime allergy, you can go for any penicillin group of drug. Meropenem allergy, you can go for any penicillin again. Astronome allergy, you can go for any beta-lactam for that matter, except ceftazidime. Cephalosporin to cephalosporin clarity. So cephalaxin allergy, you can go for ceftriaxone. Cefaclor allergy, you can go for cefepime. Cefuroxime allergy, you can always go for ceftazidime. And ceftriaxone allergy, you can go for cephalaxin. So all these have different R1 side chain. This you need to know, or you can take a screenshot, or you can come back to this video whenever you encounter an allergic reaction patient to know what appropriate antibiotic that you can give. Carbapenems. So when a patient is penicillin allergy or anaphylaxis, it is almost rare or less than 1% cross-reactivity for carbapenems. For cephalosporin allergies, also carbapenems are very safe. Multiple allergies also carbapenems are very safe. Avoid only if life-threatening anaphylaxis to penicillin, that is also very rare. And multiple proven IgE reactions also, you can take a pinch of salt for carbapenems. So more non-beta lactam drugs, there are other non-beta lactam drugs that can have allergies. So sulfonamides allergy. If patient usually complain coming to the emergency that I am sulfur allergy, and trimethoprim sulfamethoxazole cannot be given. So always label whether it is sulfur allergy or cotrimoxazole allergy, because trimethoprim sulfamethoxazole allergy is not equal to furosemide allergy and sulfonylurea allergies. So it is not the same. A different structure has different aryl amine groups, so can be given. So fluoroquinolones, if there's allergy, it is actually a true class allergy over the entire class of drug. This class allergy does not hold well for beta-lactam group of drugs, whereas only for fluoroquinolones, if one fluoroquinolone is allergy, other will also be allergic. So don't go for other group of drugs in this class. So macrolides, there is a very low allergy rate, very minimal cross-reactivity, so you can always go for macrolides. Vancomycin, that red man syndrome is actually not an allergic reaction. It is a rare rate-related histamine release from the mast cells based on the rate of infusion. So if you infuse it very rapidly, it can cause red man syndrome. So always infuse vancomycin over 1 to 2 hours. So basic bedside clinical algorithm. What was the reaction? It is just a rash or it's an anaphylaxis. So if it is an anaphylaxis, that is true IgE-mediated type 1 hypersensitivity reaction, then avoid the same drugs that have the same cross chains. So it is immune type, immediate or delayed T cell mediated. T cells are Steven-Johnson syndrome, toxic epidermal necrolysis. Exact drug that has caused it. Always know the exact drug, not the class. So avoid the drugs which have the same side chain. Go for the drug that have the different side chain that are safe. So this is matters because why this allergy delabeling matters because uh, wrong allergy labels can cause increased carbapenem use. There is increased MDR organisms that can lead to increased Clostridium difficile infection and mortality and cost of using higher antibiotics because of wrong allergy labels. So as we stated previously, more than 90% penicillin allergies are actually false, and you must be a clinician who knows to identify the side chains and also know how to delabel the patient that they are not allergic to the penicillins group of drugs. So yeah, just a rash is not actually an allergic reaction. It is just mast cell degranulation. So final mental model, drug allergy is not class based, it is structure based. So cephalosporin allergy, which side chain triggered the IgE is very important. It is not the cephalosporin allergy that matters. So now I think everything becomes logical after you see this video and the allergic reaction. If you have not known this concept previously and you're coming new to this module, and if you're new to this channel and you like this video, do like and subscribe and share with your friends. Let's meet yet another video on this series, and we'll continue this medicine beyond Harrison's. Thank you for watching.